So this is chapter 62 of your renal series. This is care of patients with kidney disorders. And the picture you see here before you is a polycystic kidney. That is a external and internal view of a polycystic kidney, and we're going to talk about that. Concepts of this chapter, again, the priority concept is elimination. The interrelated concepts are fluid and electrolyte balance, acid-base balance, immunity, and pain. Now, let's talk about the pathophysiology of the kidney. This is pretty important that you remember some of this stuff. I know that it's been a while. Remember that the kidneys participate in urinary elimination by filtering wastes, balancing fluids, electrolytes, acids, and bases. Any problem that disrupts the kidney function will limit the ability to meet that need and has the potential to impair general homeostasis. So, when we have a kidney disorder, such as an infection, pyelonephritis can occur. A pyelonephritis is a bacterial infection that will start in the bladder and it moves upward to infect the kidney itself. So this is a much more dangerous illness to have than a UTI. This is in the kidney itself. You can have acute versus chronic, and also know that abscesses can occur on the kidney. So your objectives here for this kind of patient is to prevent infection when you are caring for a patient with a urinary problem. Infection can occur if they are dehydrated, if they have urinary tract infections frequently, if they have urinary incontinence. So we have to make sure that we are meeting our objectives to taking care of our patients. So let's continue to talk about pyelonephritis. This pyelonephritis, the causes are related to an unresponsive UTI. That's when retained urine is left in the bladder and it becomes a breeding ground. Pyelonephritis occurs when a UTI progresses to involve the upper urinary system, and that would be your kidneys and your ureters. This can occur from catheters, from people who have fecal incontinence, because it's so close to the urethra. So this is a good way or bad way to get an infection. Common risk factors do include urinary retention, urinary calculi, prostate gland hypertrophy, and a UTI that is not treated. So remember that we talked about earlier that if you have a UTI, that the thing to do is to drink lots of fluid and flush the bacteria out. So one of the things that you can do that we just talked about with our objectives is to encourage your patient to increase the fluid intake for at least 2 days if they have any signs and symptoms of a UTI. So that is an important concept to remember. What is acute pyelonephritis? Well, let me tell you something. If you've ever had it, you would know. You get blank pain right in the costovertebral angle right there on your back, and fever that would be over 101 degrees, and people can chill with this. Very painful urination frequency, getting up at night and having to pee and getting up again and again and again, nausea, vomiting, and a colicky kind of abdominal pain. If you have chronic pyelonephritis, then it may be not as bad as acute, but it's still very important that it be treated. This may occur because of frequent urinary tract infections due to some sort of injury or health problem. Genetic risk. Sometimes people can have reflux, have a problem from birth with reflux of the urine in the bladder. So if it's acute, it will occur because of an infection that occurs in the bladder, and it doesn't have anything to do with obstruction or reflux. If it's chronic, it usually does occur with some sort of deformity or something that's going on that they have reflux or an obstruction. The most commonly caused bacteria is E. coli or the Enterococcus. There are a lot of people who have UTIs and a lot of people who will then develop a pyelonephritis. There are approximately 250,000 cases of acute pyelonephritis each year, and a lot of these, about half of them, are hospitalized to get IV antibiotics. Chronic pyelonephritis is generally associated, remember we said this is usually due to a reflux, so it could occur related to a ureteral reflux, vesico-ureteral reflux, or some kind of abnormality. This is more common in women. It's also after 65 years old, men can get this reflux because their prostate starts to grow and they get prostatitis and they get an enlarged prostate. Reflux of infected urine from the bladder into the ureters and kidney is responsible for most cases of chronic pyelonephritis. It's pretty common in the second trimester and the beginning of the third trimester in pregnant women, so it's really important that that be part of the teaching for pregnancy, that they do get their fluid in and get enough of their the urine to be dilute. Okay, so what are you going to ask your patients? Well, this is part of recognizing cues. And first of all, you're going to do your history. Now, history is awesome for finding cues related to what can be wrong with your patient, especially with renal patients. You want to ask them, do they have recurrent UTIs? Ask them if they have a history of diabetes or kidney stones or any defects of the genitourinary tract. Determine whether the UTI occurred with pregnancy and ask the patient about any previous episodes of pyelonephritis or similar symptoms. You can also ask if they have anything that might be blocking their kidneys. And you want to make sure that the patient is not pregnant before you do anything that includes any x-rays. Physical assessment, signs and symptoms, you are going to ask, where is the pain? You want to know what area they're having the sensation in, any signs and symptoms such as having pain, anything that has, if they've had a stone or if they have had a catheter recently. Having a condition that causes the urine to flow the wrong way. Small amounts of urine can flow from the bladder back up into the ureters and the kidneys, and people who have that have a higher risk of kidney infection during childhood and adulthood. So remember that this is pretty important that you know these things, because they can have, if they didn't treat these problems, then they can have complications such as scarring in the kidney, which can lead to chronic kidney disease, high blood pressure, and kidney failure. They can also get septic from these, from pyelonephritis. So let's see, what else do I want you to know about this? I want you to teaching them to reduce the risk of kidney infections by using good hygiene, wipe the correct way, for women especially, to wipe from front to back. That's how little girls are always taught to wipe their butts. And also to drink plenty of fluids, especially water, which can help to remove that bacteria from the body. They should empty, and I know this is going to sound weird, but after you have intercourse, women should empty their bladder. If you can urinate quickly or as soon as possible after intercourse, it will help clear the bacteria from the urethra that is caused by having intercourse. Okay, I think that's covered that pretty good. Now, assessment. How are you going to assess your patient? What are you going to notice with your patient who has come in and has complaints of pyelonephritis, or has complaints of pain and indications of pyelo? Well, you're going to notice, and to notice you have to look at lab work. You have to notice the urinalysis. You want to, because that will help diagnose if there's any infection, any presence of blood or pus in the urine, and of course they would culture that to determine the exact organism. You're going to look at the white blood cell count with a differential, because you want to know what kind of cells are being used to fight this infection. Remember, we talked about that, and that's really important that you know what kind of cells are being brought into the arena to fight this infection. Also, they may have a positive C-reactive protein, so you would check that. Sedimentation of the erythrocyte sedimentation rate, and a BUN, creatinine, and GFR. Those are your primary renal lab work that you would want to notice: the BUN, creatinine, and GFR. And also, they may do an imaging. Of course, you're going to find out, are they pregnant or not. If they are, then you have to take that into account. They may do a KUB, which is just a view of the abdomen on x-ray, or they may possibly do a CT scan. Other diagnostic assessments would be to maybe an ultrasound or something to look for any tumors or cysts in the bladder, and also to look for any antibody-coated bacteria in the urine. So how are we going to analyze this? What are we going to do? Well, our major thing when we analyze, we're going to look at our patient um, and their risk for infection, of course, and their pain. Now, this hurts. It's very deep, kind of a deep aching type pain. It's not like a kidney stone. You have flank pain and abdominal pain, kind of like it's a pressure type pain. And that's due to the inflammation and infection. They will have a risk for, of course, temperature. They may possibly have fever. They will have fever if they're having the inflammation and infection related to the pyelonephritis. The location of the pain is attributed to that retroperitoneal anatomic site of the kidney. They would have impaired urinary elimination related to the ability to conserve water, ineffective tissue perfusion. All of these are things you would analyze and prioritize for your hypothesis. Your hypothesis, your priority is going to be pain. Your secondary priority is, of course, to take care of this infection because they will have a potential for chronic kidney disease because of kidney tissue destruction. Remember, this is in the kidney itself. It's not the bladder, it's not the ureters, it is in the kidney parenchyma. So you want to make sure that this is taken care of and that this is not going to turn into a chronic problem. Well, how do you plan for this? What are you going to do? What is your response to this? Like I said, you're going to manage their pain. They may possibly admit them to the hospital and give them antibiotics and fluids. And how long they have to stay in the hospital depends on how quickly it clears up. And also, while they're there, you're going to teach them to manage recurrent kidney infections and make sure, and of course, sometimes they may even have to refer them to a nephrologist who is an actual kidney specialist. Or if they need surgical management, they would be referred to a urinary surgeon, such as a urologist, for an evaluation. If they have anomalies that are causing this or causing frequent infections, then that might be something they take care of using surgery. Sometimes they will give the fluoroquinolones for the infection. They would make sure that your patient knows to complete the entire prescription that they're given. And then they would have follow-up urine culture results if they had a complicated course, and if they are healthy people, they may not, but if they have complications, then they'll need a follow-up. And any patient who has a complicated UTI or has a pyelonephritis should be sent for follow-up imaging, because you want to prevent any chronic kidney disease. Okay, let's transition them then to home. This is they've had their treatment, they've had whatever they needed, they've had their antibiotic, and now they're going home. Possibly they may need, as we said, a repeat urine culture to make sure that the infection has cleared. If it is still present, then they may have to take another round of antibiotics. Drink fluids, especially water. Can't say that enough. Fluids can help remove bacteria from the body when they urinate. And tell your patients and yourselves to urinate as soon as you need to, because when you avoid urination, you can the urine will sit there, and if there's any bacteria, then it will grow. Again, we said teach them to empty the bladder after intercourse, and urinating as soon as possible will reduce the risk of their infection, and to wipe carefully, and especially after a bowel movement. That will you always wipe from front to back. And also, it's really a good idea to avoid using feminine products in the genital area, because they can be irritating to the skin. So those are some of the teaching mechanisms that you would use when you help your patient with their transition to home care. So how are you going to evaluate your outcomes? One thing is that the pain is controlled. That's what you would say would be your goal. You want to make sure the pain is controlled. And also be knowledgeable about the disease, treatment, interventions to prevent or reduce chronic kidney disease progression. Really, overall, the majority of cases of pyelonephritis are managed in an outpatient setting, with most patients improving with oral antibiotics. Usually, young women are those most likely to be treated as outpatients. There's still a significant morbidity and mortality that can be associated with severe cases of pyelonephritis. That's a study has been done, of course, lots of studies. We do best practice based on studies. Old age, older than 65 years, male gender, impaired renal function are associated with increased mortality. So it's important that proper recognition of the pyelonephritis is done, that you see what's going on, and that they get prompt and adequate treatment. Okay, so that's all about the pyelonephritis. One thing I want you to remember about pyelonephritis, the big thing, is that it is an infection of the kidney itself coming up from the bladder and the ureters. Okay, it's really important that you remember that. Now let's talk about acute glomerular nephritis. It too can be primary and it can be secondary. It develops suddenly from an excess immunity response or immune response from the kidney tissues, and it causes altered urinary elimination. And the cause is generally infectious. A patient who has acute renal injury caused by glomerular nephritis is classified as intrinsic or intrarenal failure. So this would be something that has developed to injure the glomerular in the kidney itself, not in the ureters or the bladder or anything. It's in the glomeruli. So this is important that you know that. They can go into acute renal failure and get really, really sick. So let's talk about it. Glomerular nephritis related to autoimmune diseases or infections. If it's related to the infections or autoimmune diseases, it is an inflammation of the blood vessels. um, this scars the glomeruli. And a lot of times this is brought on by having a streptococcal infection. So it's a post-streptococcal glomerular nephritis. It may occur after an infection of group A beta hemolytic streptococcus, strep throat, or skin infections such as impetigo. That is bolded. That is important that you know that. If you have a patient who has presented with some of the symptoms that we'll talk about, you're going to want to know, have you recently had a strep infection, whatever kind? It's group A beta hemolytic streptococcus, strep throat, or skin infections. Also, there are some autoimmune diseases such as lupus, Goodpasture syndrome, IgA nephropathy. That is one of our immunoglobulins, and polyarteritis, and Wegener's granulomatosis, which is also a vasculitis. Glomerular nephritis may be caused by problems with the body's immune system. Sometimes we don't know what causes it, but we got to do a history. You will see that repeated over and over and over. This is how you recognize cues. This is by looking at their history. Ask them about recent infections and find out what kind they are, any illnesses that they may have, or surgery, or any systemic diseases such as lupus. What you may see is blood and protein lost in the urine. So you're going to look at, of course that will be something we'll look at with their labs. It can develop very, very quickly, and kidney function is lost within weeks. This is called rapidly progressive glomerular nephritis. There are two types of glomerular nephritis, acute and chronic. The acute form develops suddenly, and sometimes you get better on your own. Other times the kidneys may stop working unless they get treatment. So that is why, if you will remember, anytime you have strep throat or impetigo or anything, you're always, always, always put on antibiotics. Always. You're going to do a physical assessment. Because this can develop acutely, you're going to look at the skin for any lesions or incisions, and you're going to look for edema, puffiness in the face, or anything that can indicate periorbital edema around the eyes. They can get short of breath, and the blood pressure may go up. They can have high blood pressure. So if patients have these things, they need to get to the doctor right away. Your laboratory assessment, we talked about a little bit. You will find protein and blood cells in the urine if they have acute glomerular nephritis. In some cases, they have to have 24-hour urine, and they will have to assess for the creatinine, the 24-hour urine creatinine, and also they will do a serum albumin because they will be losing their protein. If they lose their protein, then their albumin will change. They will have low serum albumin. Their serum creatinine, as we said before, is a definite indicator of any renal problems. So you're going to watch that. They may possibly have elevated BUN, and of course you're going to want to know what their um, glomerular filtration rate is. It may be low in people who have acute glomerular nephritis. It may drop, so you want to know how it's doing. Sometimes in some occasions they may do a kidney biopsy, and they will help, that biopsy will help determine which treatment is best. But that's not a usual thing with acute um, glomerular nephritis. More common with chronic. But we're talking about acute right now. So, when we were talking about a while ago, you're looking at your patient and you're looking at clinical manifestations, you may see something called a nephrotic syndrome. Now, this nephrotic syndrome is usually it happens between 1 and 2 weeks of that strep infection, and then 2 to 3 weeks if they have impetigo. And what you would see would be the urine would become a muddy brown. This is caused by hemolysis of the red blood cells that should not be seen in your urine, but they have penetrated through the basement membrane and went into the tubular system. So that is a defect of the glomeruli. So that would be an indication that they have blood in the urine. Okay, periorbital edema, most noticeable on waking. It occurs suddenly. They wake up one morning a couple of weeks after this infection and their eyes are all swollen shut. So, in these patients, 80% of them will have high blood pressure, hypertension, and that's bolded also, along with a muddy brown urine. So I expect you to remember that and to know it, because that's important for you as a cue for you to see so that you can pick up on this problem that the patient may be having. Would they have flank pain? Maybe. Oliguria? Yes, they could. General weakness and malaise and anorexia may be present. So what's going on to cause all this? These complexes, these immune complexes, become trapped in that glomerular tissue, and it causes the glomeruli to swell, and then you have capillary cell death. So you see why you get those red blood cells in the urine. The prognosis will vary dependent upon the cause, but usually they will have spontaneous recovery. If this is chronic, you will not recover. You won't have recovery with a chronic glomerular nephritis illness. What do we treat them with? Like I said, they're going to get antibiotics. They're going to get, if they have a strep infection, they need oral penicillin. They need, if they're allergic to penicillin, they'll get erythromycin. If they are edematous, they will get diuretics. And if they have hypertension, they're probably going to give them either calcium channel blockers or ACE inhibitors. And you've had those before, you know what they are, but it's important that you know that why they get them in this setting, because of the hypertension. The ACE inhibitor will protect the kidneys. It is kidney protectant. And of course they can, the calcium channel blockers are also a good drug of choice. Okay, let's take some action here. What are we going to do? How are we going to treat this? And of course, we're always, as nurses, interested in prevention. So you want to tell your patients how to manage their infections, when to go to the doctor, when to be worried, when to make sure that they have anything that's not clearing up, because you want to prevent complications. That's the main thing. You want to prevent kidney injury, and you want to provide appropriate patient education dependent upon what you find in the history. Again, history is hugely important for these patients. You need to know what's going on with them. Now let's discuss chronic glomerular nephritis, or CGN. This can occur without a previous history or a known onset. Kind of scary, isn't it? You may not know what actually caused the damage, because by the time you find out, there's been so much damage to the kidney that it has atrophied, and you can't tell what the causative problem is. So what happens, it involves the progressive destruction of glomeruli and eventually hardening or sclerosis, and that is called glomerular sclerosis. You will not have recovery with a chronic glomerular nephritis illness. You can manage it, but it will not go away. It will develop over years to decades. It is the third leading cause of end-stage kidney disease, and the progress varies depending on the specific cause. The symptoms may include mild proteinuria, hematuria, hypertension, fatigue, and occasional edema. They do not know what the cause is. And what happens is you lose nephrons. So your glomerular filtration rate will decrease. So how are you going to know this? You're going to do a history. You want to know what their health problems have been, what their exposures are to infection, if they've had any fatigue, lethargy, or elimination pattern changes. You also want to know what you see. You want to see your patient. You want to assess them. This is your job as an RN, is to do a physical assessment, the signs and symptoms of chronic glomerular nephritis. May include that they have circulatory overload because they're not getting rid of their waste products and urine, so the fluid is not being eliminated. They may have crackles in their lung related to edema or fluid in the lungs, and then they may have some uremic symptoms, and we'll talk about that a little bit later too. Psychosocial assessment, they may be scared and not know what's going on and be hit with this, and it's kind of devastating. How are we going to also notice? We're going to notice because we're going to look to see what's going on with our patient. We're going to look at the diagnostic assessment, the urinalysis. We're looking for protein. We're looking for any blood in the urine. GFR. Why are we looking at the GFR? The glomerular filtration rate. This is how the fluid is being eliminated from the body along with the waste products, and that is your glomerular filtration rate. Very, very important. Serum creatinine, indicative of any kidney damage. BUN, that also is looked at. It's not as definitive as the creatinine, but we still look at it. Sodium and phosphate levels, ABGs, because we're looking at the acid-base balance, And of course, x-rays and CTs may or may not be indicated. But if they are, we will know what they say. That's part of our job. So what do we do? What actions do we take? What are our interventions? The biggest thing here is to slow progression of disease and to prevent complications. So that may include some dietary changes, protein changes. It may indicate that they need less fluid intake, dependent upon how well they are getting rid of their fluid, and some drug therapy, definitely related to their acid-base balance and related to their output, their urinary output. You want to make sure that they're getting their diuretics if they need them, and also some other drugs that will help them with their electrolytes. Eventually, if it does not slow really slow before they die, they may at some point need dialysis or transplantation. And that's why they're scared and they don't know what the future may hold. Now, I told you a while ago we were going to talk about the nephrotic syndrome. I wanted you to get through the problems with the glomerular problems, but nephrotic syndrome involves, of course, the glomerulus. Because the permeability will increase and it will allow bigger molecules like blood and protein to go through the urine or through the membrane into the urine, and it will be excreted. So they lose massive amounts of protein into the urine. And when you lose a lot of your protein or your albumin into the urine, you will develop this nephrotic syndrome. It will cause a decrease in the plasma albumin levels, which will cause edema formation. The most common cause is altered immunity with inflammation. Remember, we said in these patients, they will usually present with hypertension, and I mean hypertension, really high blood pressures. Because of all this, the retaining fluid, they have edema formation, and they're losing blood. So you're going to have some problems with the high blood pressure. So this is going to have to be treated, obviously. What are you going to do about it? Well, the main feature, because it's that increased protein elimination with severe proteinuria, you're going to treat it using ACE inhibitors. Like I told you before, ACE inhibitors can protect the kidney. They can decrease that protein loss in the urine. They may need heparin, dietary changes, sodium and protein. They may need more protein and less sodium. Mild diuretics to control the edema and the hypertension. If their GFR is really decreased, they will definitely have sodium restriction. And what you want to do is maintain an adequate blood flow to the kidney. You may see them have ankle swelling or swelling of the face and hands, and like I said, it can come on really suddenly. The latent period, remember, is between 1 and 2 weeks of strep infection. Why do they get heparin? They get heparin because it can help reduce those vascular defects, and it can actually improve the kidney function. What is our pharmacology for nephrotic syndrome. Good old glucocorticoid therapy. They would get oral prednisone, usually 2 milligrams per kilogram a day, split in 2 doses, and that will be given daily for 4 to 8 weeks. And of course, that is individual patient usage. And always remember that they wean people off these doses of oral prednisone. They have to be weaned off because it can affect the um, adrenal function. Infections must be treated immediately with the appropriate antibiotic. If they have diuretic or have problems with edema, they certainly can use diuretic therapy, and usually they will give them a loop diuretic. A loop diuretic is one such as Lasix. Also, the patient may need to get saltpore albumin infusion that can help them with their albumin loss. And always, and this is one of the things, these people are more prone to development of any immunosuppressing disease, and so they would give them pneumococcal vaccine after they have gone into remission. Now let's talk about nephrosclerosis. This is a degenerative disorder resulting from changes in the kidney blood vessels. What happens is the capillaries are an integral part of the nephrons, and they're responsible for oxygenation. When those nephrons are destroyed or impaired, such as when you have, like, say, pyelonephritis, there could be progressive decline in kidney perfusion because the nephron blood vessels can thicken, and it can cause a decrease in the kidney blood flow. The kidney blood flow is essential to our survival. Hypoperfusion will affect the kidney's production of erythropoietin, and they can then get anemic. Whew, the things that can happen to our bodies. A decrease in the red blood cell level then, of course, would decrease our oxygen supply to the kidney. Lord love a duck. We need to make sure that hypertension is treated. This can happen also with atherosclerosis and with diabetes. This is the culprit here with diabetes. It causes these nephron blood vessels to get thick and get narrowed. It can be reversible, or it can progress on to end-stage kidney disease. How are we going to take care of these patients who have these problems? We must control their hypertension. And again, ACE inhibitors are hugely important in the function of the control of the hypertension. And of course, diuretics. The diuretics will decrease the amount of fluid on board, which will also decrease the blood pressure. And of course, you want to reduce albuminuria. Adherence to therapy is very, very important for maintaining their health. Okay, so let's move on now to polycystic kidney disease. Polycystic kidney disease is a genetic disorder. Genetic disorder. And what happens is that fluid-filled cysts develop in the nephrons. Oh, remember what nephrons are? Fluid-filled cysts develop in the nephrons. It is an inherited disorder in which fluid-filled cysts become present in the nephrons. Usually, if it's a dominant form, only a few nephrons have cysts until the person reaches his or her 30s. In the recessive form, nearly 100% of the nephrons have cysts from birth. They can develop anywhere in the nephron as a result of abnormal kidney cell division. Over time, these small cysts become larger and they become more widely distributed. The cysts damage the glomerular and tubular membranes. And as the cysts fill with fluid and enlarge, the nephron and kidney function become less effective. And the kidney tissue is eventually replaced by these non-functioning cysts, and they look like clusters of grapes. The kidneys become very, very large, and they can enlarge to 2 to 3 times the normal size of the kidney, becoming as large as a football. And they may weigh 10 pounds or more each kidney can. Well, of course, this is going to displace your other organs in there, and the patient's going to hurt. And then, to beat all that, these cysts are going to rupture and bleed, and they're more prone to infection. So what you're going to see is that full gamut of what we've talked about before with some of the other problems. They're going to have hypertension. They're going to feel like their belly is full, and quite frankly, it is full. They're going to have pain. The cysts may bleed. They may have hematuria. They may develop kidney stones, infections, and systemic disease. And I have talked about a bit about the autosomal dominant or autosomal recessive trait. The dominant is the most common inherited kidney disease, and there is no way to prevent PKD. So there's a 50% chance of parents of passing this mutated gene to their children. So of course, one of the things you're going to do is provide genetic counseling. About 600,000 people of all ethnic groups in the United States are affected, men and women equally. And you can imagine that they're going to also develop cardiovascular complications because of the hypertension and the damage to the kidney itself. And so the primary cause of death is due to hypertension. So in these patients, control of that blood pressure is your priority. So kidney failure, obviously, is going to be a common problem for people with polycystic kidney disease. High blood pressure, back or side pain, cysts that you can palpate or even see huge kidney when you see the patient when they lie down, blood in the urine, frequent urination. All of these things can occur with patients who have polycystic kidney disease. They also can develop or will have polycystic liver disease. About 75% of them will have that in addition to. So, if a patient has a first-degree relative, a parent, sibling, or child with polycystic disease, kidney disease, they should actually see the doctor to discuss the pros and cons of screening for this disorder. And when I say screening, think about that. You're going to get screened for it to see if you are going to develop it. And if they screen you and you do have cysts, then there's nothing they can do about it but treat these things, the high blood pressure, the pain, kidney stones, and infections. So that's kind of a, I don't know if I want to know or not. Of course, how to see it, ultrasound is the most useful tool and the least painful, but CT and MRI is also appropriate. So, you've got to know their family history. And sometimes people died early and they don't know what caused their death. And sometimes this just comes as a shock to a person because they don't know that they have a family history. So, but family history, of course, is super important. You also want to know what kind of pain they've been having, if they've been constipated, any urine changes, hypertension, and headaches, because hypertension, of course, can cause headaches. Your physical assessment signs and symptoms will you may see that they have bright red or colored urine when a cyst ruptures, and that will cause pain, can cause infection. So these people are facing some pretty severe psychosocial problems. You want to know, if possible, the age at which the problem was diagnosed in their parent. Sometimes the first thing they have is that pain. They may have flank pain, or they may have a kidney stone. So this is a pretty bad problem, and especially kids who have grown up and not known that this is a problem, or lost a parent at an early age and didn't know that they had the gene, then they're going to have uncertainty, loss, and fear. And oftentimes it's fear of their children and should they have children. This is a very, very uncertain time for people who get this diagnosis. Okay, we're going to look at the ultrasound. This is the primary method for diagnosing this. They will look for the size of the kidney. They may use the ultrasound or the MRI or a CT scan. You're going to look at, of course, your labs, because you're going to need to know what their kidney function is related to their lab work, creatinine clearance, their serum creatinine, and their GFR. And a urinalysis would show definitely protein in the urine and maybe hematuria, possibly even infection if they've had a ruptured cyst. So what are you going to do? Well, again, maintaining their blood pressure at a safe level is of utmost importance. That's your priority right there. You absolutely have to manage their pain, but the priority is that they manage their blood pressure. Comfort strategies, preventing constipation. In these patients, do not use NSAIDs because of their tendency to reduce kidney blood flow. That is why we do not use NSAIDs in any renal patient. And it's best for all people not to use NSAIDs if they don't know what their GFR is, or if they don't know if they have any problems with their kidneys. You really need to be very cautious with the use of NSAIDs. Also, of course, you don't really want them to take aspirin, which is an NSAID, and because it can cause bleeding. They may need antibiotics. They may need Bactrim, Septra, or Cipro. You want to make sure they have adequate fluid intake. And all of this is geared to slow the progression of chronic kidney disease. So that what you're doing is you're trying to hold on and you're trying to keep the kidney as healthy as you can as long as you can. Now, to maintain that blood pressure in your treatment plan, the drugs of choice for hypertension are angiotensin converting enzyme inhibitors and or angiotensin 2 receptor blockers. We call these ACEs or ARBs. We also want to control any abnormalities related to renal failure, and that would include some drugs to control the electrolyte levels. And I have them listed here for you. Diuretics, of course, blood pressure medications. Sometimes they need calcium carb, calcium acetate. Some of these are, of course, based on what their blood levels show. If they have a urinary tract infection, it must be treated, and they will treat it with cephalosporins. And they will treat the hematuria. They will reduce the abdominal pain, which is caused by those enlarged kidneys. And they may use opioids that have acetaminophen in them. These people hurt, and they should not have to hurt. But again, do not use NSAIDs. If that comes up on a test and you choose to use NSAIDs, you're going to miss the question, because you do not use NSAIDs because they can have a nephrotoxic effect, and you sure as heck don't need that with these patients. Okay. Care coordination, transition management. These people need some healthcare resources. The Polycystic Kidney Disease Foundation and the National Kidney and Urologic Disease Information Clearinghouse, or the National Institute of Diabetes and Digestive and Kidney Diseases. They all are involved in research, and they will provide the best in education for your patient about PKD. They have lots of pamphlets, although there is a fee for some materials, but there's enough free stuff out there that you can get what they need. The National Kidney Foundation, which is what the NKF is, and the American Association of Kidney Patients also have resources and support. This is huge for these patients. Don't let them think they're alone. Okay, now let's talk about hydronephrosis and hydroureter. Problems of urine elimination, again, with outflow obstruction. That's what this is going to talk about, or what we're going to talk about here. It can be caused by obstruction within the kidneys, such as a stone, or in the ureter, such as with a stone, or with some kind of stricture that's occurring. And when you have hydronephrosis, the kidney enlarges as the urine collects in the renal pelvis and the kidney tissue, because the capacity of the renal pelvis is normally 5 to 8 milliliters. When you get an obstruction in the pelvis of the kidney, or at the point where the ureter joins the renal pelvis, it can really distend that renal pelvis, and the kidney pressure will increase as the volume of urine increases. And sometimes in only a matter of hours, the blood vessels and kidney tubules can be damaged extensively. So, how are you going to recognize cues? Again, history. You obtain a history from the patient. You focus on known kidney or urological disorders, say a history of childhood urinary tract problems that might indicate undiagnosed structural effects or defects. So ask about their usual pattern of urination, the amount, frequency, color, clarity, and odor, and ask them about recent flank or abdominal pain. Chills and fever and malaise may indicate that they have a UTI. So you want to question them quite well about that. You're going to look at their flanks, and you may see the area, of course, would be on the retroperitoneal area, or where the iliac, close to the iliac, where the vessels cross or where the ureters enter the bladder. And what happens is that with this pressure, it causes the glomerular filtration rate to decrease or even cease, and complete necrosis of that affected kidney can occur. Causes, of course, of hydronephrosis or hydroureter include tumors, stones, trauma, structural defects, and fibrosis. Early treatment of the causes can prevent hydronephrosis and prevent permanent kidney damage. Remember what I said, permanent kidney damage can occur in less than 48 hours in some patients. So if they're having pain, or and they will have pain, trust me, it hurts. When I had my kidney stones, I always had hydronephrosis, and it hurt like a mother, let me tell you. It does hurt. So they won't sit around and tolerate this pain. So usually you can get something done within 48 hours before the kidney damage occurs. What do you do? If it's urologic, then you're going to treat whatever's going on in there. If it's a UTI or if it's a stone or whatever it may be, you're going to look at the urinalysis and see if they have any white blood cells in there. And they may possibly even have to go ahead and do IV urography, which will show ureteral or renal pelvis dilatation. They can see outflow obstruction with renal echography or CT. If it's caused by a stone, it can be located and removed, which is a good idea. And they may, of course, need a stent in there because it irritates that ureter, and it can cause it to be swollen, and then you're back with the same problem. When they have radiologic interventions, they may have to do a nephrostomy and drain that urine out until they can get the problem fixed. It will divert the urine externally, and it will prevent further damage to the kidney. People who have these staghorn stones may have to have that because it takes a while to get that out, and sometimes they have to go in open and take those out. So remember that they may have a little blood-tinged urine for a while if they do have a procedure done, and you want to make sure that you check them for infection. Okay? Renovascular disease. This is a vascular problem, obviously, and this affects the renal arteries, and what happens is you can have renal vein thrombosis or renal artery stenosis, atherosclerosis, or you could even have a blood clot that causes ischemia and atrophy of the kidney tissue, which will lead to severe impairment and reduces the blood flow to the kidneys themselves, and that causes ischemia. It causes the kidney to atrophy. It leads to severe impairment of urinary elimination, fluid and electrolyte balance, and acid-base balance. And you may see in people who are over 50 years of age who've never had hypertension suddenly develop hypertension. So, what are your cues? You are going to look for significant, difficult to control hypertension. You want to know if they have poorly controlled diabetes or sustained hyperglycemia. Look at their serum creatinine and look at their GFR. That's going to be your major cues that something's going on in the kidney. The diagnosis may be made by MRA, renal ultrasound, or radionuclide imaging, or renal arteriography. Remember, hypertension usually occurs first after age 40 to 50. That gives you a clue or a cue that something's going on here. And usually they will do a renal arteriogram so that they can look at the vessels. Treatment would depend on what caused it, what the extent of narrowing is, and the condition of the blood vessels that surround the kidney and the kidney area. Sometimes they can give drug therapy, of course, for blood pressure. You want to make sure their blood pressure is maintained, but in a safe, normal range. You don't want them to get too low on the blood pressure because you've already got a problem with the renal blood flow. And sometimes they can do a stent and go doing the endovascular study, and they can actually put a stent in there to open it up. And occasionally they'll have to have a bypass, a renal artery bypass therapy or surgery. Okay, vascular complication of diabetes mellitus. This is where we run into such problems with people who have diabetes with renal disease. It is the leading cause. Diabetic nephropathy is the leading cause of chronic kidney disease worldwide. The severity is related to the degree of hyperglycemia the patient generally experiences. The higher the blood sugar, the longer it's high, the more problems that's going to occur with the vascular or the vasculature of the kidney. So, management is of utmost importance. Management of what? Obviously, they got to manage their blood sugar. Now, renal cell carcinoma. This is also called adenocarcinoma of the kidney. It is the most common type of kidney cancer, not bladder, not ureters. This is kidney cancer. And their symptoms will include anemia, erythrocytosis, hypercalcemia, liver dysfunction with elevated liver enzymes, and increased sedimentation rate and hypertension. Most patients with this cancer have either anemia or the erythrocytosis, but not at the same time. It will usually metastasize to the adrenal gland, which sits right on top of the kidney, the liver, which is right over next to the kidney, the lungs, which are just right up from the kidney, long bones, or to the other kidney on the other side. Recognize cues. What do you need to know? You want to get their history. What are their risk factors? Did they have weight loss? Do they have urinary changes, pain, fever? They may very well have flank pain, and they may have blood in the urine. However, that is a late sign. And of course, you may feel a kidney mass. You would do a urinalysis, hematologic studies. Do they have anemia? Serum creatinine again, what the function of the kidney, is it compromised, a BUN? They may do a CT, MRI, ultrasound, or a kidney biopsy. And remember that we talked about this a little earlier for bladder cancer. Well, the same applies here. The risk is higher for adults who use tobacco or are exposed to cadmium and other heavy metals, asbestos, benzene, and trichloroethylene. Well, what are we going to do? We really, really want to prevent metastasis, don't we? We want this to stop here. And the main goal, is to prevent the metastasis. They may do microwave ablation or cryoablation to slow the tumor growth. In these cases, chemo has very limited effectiveness. So generally, what they will do is take that kidney out. They will do a nephrectomy. And of course, the kidney is surrounded with blood, with vasculature. So the bleeding is a major concern. They may even do an embolization prior to surgery before they take the kidney out to reduce the bleeding risk. Okay? Kidney trauma. Well, this can be caused by penetrating injuries. They're very difficult to detect. Blunt trauma may show bruises over their back or abdomen, and so you suspect that there may be internal injuries. It can be a penetrating wound. Some urologic treatments or procedures can cause kidney trauma. And this is classified into 5 grades depending on how severe it is. It's from 1 to 5, with 1 as a low grade, bruising, up to a 5 as shattering, completely obliterating the kidney and tearing the blood supply away from the kidney. Most complications in renal trauma are urinary leakage or delayed bleeding from the damage. They can form abscesses, and people can develop hypertension after they have kidney trauma if the damage is severe enough. And when I say lacerations to the kidney muscle itself, to the tissue, that's called the parenchyma. That is called parenchymal lacerations. If they have parenchymal lacerations to the kidney, they should be in the hospital. They are kept on bed rest, and they are given antibiotics until the urine clears up. The blood clears out of the urine. Kidney trauma. Well, you got your cues again. You got to need a history. You got to have a history. You need to know what the heck have they been into. Kidney is the most common organ in the urinary tract to be injured by severe trauma. So, duh, ask them, have they had any trauma? The cardinal sign of a renal trauma is hematuria, but the hematuria can just be a little tiny bit, or it can be massive depending on the severity of the injury. Of course, you know that you have to know the mechanism of the injury. Was it a blunt trauma, or was it a penetrating wound? How hard did they hit whatever the blunt trauma was? You're going to assess for their pain. You can look at their urine and, of course, their circulation. You do blood pressure, vital signs. Lumbar and abdominal pain may occur. They may get a rigid abdomen and have local tenderness. So if you see a rigid abdomen, you're going to totally suspect there's blood in that peritoneum from something. A urinalysis, of course, a H&H, ultrasound, CT, and a KUB are pertinent for this diagnosis. Non-surgical management, wait and watch and wait and watch. Drug therapy, sometimes they will just give them medications, watch their blood pressure. Fluid therapy, you want to clear that blood out as quickly as possible, and of course maintain their fluid volume. And then sometimes interventional radiology may be appropriate. They may need to go in there and see what's going on. They may need components to replace the blood, some blood components, and you're going to monitor these people for shock. Most are managed without surgery, but they can require a laparotomy if there's massive trauma to the abdomen. And the aim is to repair that injured kidney and restore its elimination. But if the kidney is severely injured, it may require that it be taken out. Okay. Kidney trauma coordination and transition management. The most common complications are urine leakage and delayed bleeding. So you would instruct the patient to check the pattern and frequency of urination and note the color, clarity, and amount. Chills, fever, lethargy, and cloudy, foul-smelling urine could indicate they've developed an abscess or even a UTI. So make sure that they know how to check their blood pressure and check for possible development of hypertension. Okay, case study. A 40-year-old client is admitted to the ED with fever, chills, severe right flank pain. Her heart rate is 114 and the respiratory rate is 30. She reports recently being treated for a UTI infection. She has fever, chills, severe right flank pain. Her blood pressure, we don't know what her blood pressure is. She reports recently being seen for a UTI. Assessment reveals tenderness of the right costovertebral angle, the CVA. What condition would you anticipate, and what laboratory test do you think would provide you with some cues? What do you think? What would you anticipate here? See, she's got fever, she's got chills, she's got severe right flank pain. Doesn't tell us what her fever is, does it? Her heart rate's up, way up. She's breathing fast. So she's recently had a UTI. So what are you thinking here? Did that move? Has the infection gotten up into her kidney itself? So does she now have what? Pyelonephritis? I think so. What do you think? There it is. Acute pyelonephritis. And of course you're going to do a urinalysis. It should be positive for nitrates, white blood cells, bacteria. Do a urine culture and sensitivity. Blood cultures, big time. Yes, she must have blood cultures. She may have, they may do a C-reactive protein, which would indicate inflammation, infection, and erythrocyte sedimentation rate. All of that would be diagnostic of infection. So, here's our little darling select all that apply. For which diagnostic test does the nurse prepare the client? May have pyelonephritis. I know I'm going to do some labs, don't you think? Definitely. Diagnostic tests. What do I need to know? What do I need to know? D and E for sure. But what about those x-rays? What do we need here? Let's see. A, B, D, and E. All of these diagnostics can be used when acute pyelonephritis is anticipated. The only one that stood out there was a thoracic MRI. Why would we go up into the thorax to check for a pyelonephritis? So that was your ringer there. The rest of them, yes, they needed all of those diagnostic tests. So 2 days later, during the assessment, the client expresses embarrassment. She reports not taking the full treatment of antibiotics prescribed for the UTI she had recently. What is the appropriate nursing response? You want to say, Are you going to say, the next time you will know to do better? Or why didn't you take all your medication? And then superbugs can develop when antibiotics are not finished. Or how about good old psych? Can you tell me more about why you didn't take all your antibiotics? That one's pretty much no-brainer, huh? You want to be non-judgmental, so that's your last one there. The response D is non-judgmental and encourage the patient to share more. Even though you want to just wring their little necks and say, look, you could have prevented this if you had just done what you were told to do. You can't do that. She's already embarrassed and she already knows that she screwed up. So let's let her talk about it, and maybe she will convince herself to not do this again. Don't judge. So now we have a nurse caring for 4 clients. Which client does the nurse identify as the highest risk for acute pyelo? Would it be an 18-year-old male with spinal cord injury, a 24-year-old female with urinary reflux, a 31-year-old male with HIV infection, or a 40-year-old female with urinary tract stones? What causes pyelonephritis? We got to think about this first, okay? What causes this pyelonephritis? It's urine that's infected going back up into the kidney itself. The 18-year-old male doesn't say where the spinal cord injury was or if he even has any problems voiding or
has to do self-casts or whatever. It doesn't say. The 31-year-old male with HIV infection does not contain a high risk of pyelonephritis. A 40-year-old female with urinary tract stones is more apt to get hydronephrosis. So your answer here is the one that talks about the urinary reflux. Acute pyelonephritis is most commonly seen in a 20 to 30-year-old female. Reflux is that key contributor that we were looking for. If the other people had pyelonephritis, it might be a chronic pyelo rather than acute. The nurse is caring for a client with polycystic kidney disease. Remember what that is. All those cysts that are in the kidney and destroy the nephrons. Which assessment finding requires immediate nursing intervention? Immediate. Oh, and please, Lord, don't let them miss this one. Please, 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 please. The temperature has no meaning here. What requires immediate nursing intervention? What do we have to control? What is the most important thing that we have to control? It's the blood pressure. Clients with polycystic kidney disease often have high blood pressure, and the cause of it is related to kidney ischemia from those big old cysts they're growing. When they're compromised, it compresses the vessels, and the blood flow to the kidneys decrease, and the renin-angiotensin system is activated, which will raise the blood pressure. So control of hypertension is a top priority, and if you ever see that as a choice on some kind of test question like this, you know that's your top priority. It can just disrupt the process that leads to further kidney damage if you can go ahead and get that controlled. The other thing is you can assess that after you've controlled their hypertension. Not that they're not important. Question 3. Which assessment finding does the nurse anticipate for a client with chronic glomerulonephritis? Select all that apply. Now this one you got to think a little bit about, right? This is chronic glomerulonephritis. Would they have increased urinary output? Would they? No. Decreased. What about their specific gravity? What would it be? 1.010? Nah, that's dilute. Red blood cells in the urine? Definitely, definitely. A serum creatinine level of 5 milliliters of dilution? A sodium level of over 135 milliequivalents per liter? This is chronic glomerulonephritis. The answer here is B and C. They would have decreased urinary output. And the serum creatinine would throw me. It would throw me because that's elevated. But you're thinking, okay, it doesn't say they have chronic kidney disease, it's chronic glomerulonephritis. So their creatinine would probably be less than 6. So that's not really going to factor in here, but it would throw me off. and the sodium level is okay. The other findings are really not anticipated. So options B and C are expected findings. Expected findings. I do not like that question. Okay, that is it for chapter, what was it, 63. Hope y'all enjoyed, no, wait a minute, chapter 62. We will go into chapter 63 next. So this was chapter 62, which is care of the patient with kidney disease or disorders. Okay,